See my screen. Hello?
Yes, we can see it.
Okay. So, just like we normally do, of course, we still have our step one knowledge. So, we are going to start today's section by looking at this question we have here. Okay. So, a 26-year-old woman, gravida 1, para 0, at 20 weeks gestation, comes to the office due to non-productive cough, chest tightness, shortness of breath for a month. So non-productive cough, chest tightness, and shortness of breath for a month. The symptoms occur a few times a week, mostly at night, and have occasionally awakened the patient. They have recently been bothersome during the day. They are not worse during meal or while lying down. The patient is asymptomatic during a visit. Medical history is significant for asthma in middle school, but she has not experienced symptoms or needed an inhaler since her late teenage years. The patient has no known environmental or drug allergies. She has never used tobacco or has been exposed to secondhand smoke. Blood pressure is 118, 70, and pulse is 74. Fetal heart rate is 152 beats per minute. The oropharynx is clear. Chest auscultation reveals normal breath sounds. The uterine fundus is palpable at the umbilicus, consistent with 20 weeks gestation. Which of the following is most likely diagnosis? What do we think? A woman with non-productive cough, chest tightness, dyspnea for a month. The symptoms occur usually at night, so it's nocturnal, and sometimes it wakes up the woman from her sleep. They don't get what?
We can. Hmm.
Yeah, I'm listening.
We
Listening.
sorry, Dr. Bawali is joy. We can try removing things that we're not too sure of. So let's take out PE. PE is off. The reason is because usually PE comes from there must be a triggering factor which this one doesn't have here.
Okay.
Obviously, PE causes dyspnea, but it would not cause non-productive cough and shortness of breath for just a month. And there was no history of maybe, for example, if she had a long fat bone trauma or something, or a resection of a. So let's take that one off. Then we'll take the acute bronchitis out.
Mm-hmm.
I was thinking bronchitis, but when they said non-productive cough, it just ruled out everything for me. And I know they usually have those because of the hypertrophy and the hyperplasia, although that might be chronic, they usually have this productive cough for consistent 3 months. So that is still in might still be in the picture. Then let's take out now I'm stuck with she has asthma. They already told us she has asthma.
Fantastic.
And yeah, they already told us she has asthma. So and
Hmm.
they say it happens during the day.
Yes.
Mm.
And again, another thing that is not in keeping with acute bronchitis, one thing to look out for is that the person is going to have like a prior history of viral infection.
Viral infection.
Very, very
Agreed.
important. Very, very
Those
important.
rhinovirus, influenza, or parainfluenza, right?
Yes, yes, yes. Okay.
So that one will go off. So now, dyspnea of the pregnancy, that one is off because it will only cause hyperventilation. It will not cause this issue. So
Nice. Nice.
it it will
So,
cause because usually they usually have this hyperventilation now
mhm.
because of pregnancy and everything. So that one with the the acidosis thing, just that one is off.
Yeah,
Now, Gerd looks very, very, very tempting.
good.
I would not lie. Gerd look very tempting
Very
because
tempting. Mm-hmm.
pardon?
Mm-hmm. Yes, I'm listening. I'm with you.
Yeah, they look very tempting, and especially they said they are not worsened doing the meals or lying down.
Yeah.
So Seriously, if I'm to pick, I'll pick Gerd here and move on.
But you already said it. You said not worse during meals
Oh,
or
sorry,
after.
not worse doing meals. I started worsening doing meals. So Gerd, and Gerd will have more from LES. They would definitely want to mention LES just to bring it out. Kind
Yeah,
of
yeah,
mm.
yeah.
Let's go with asthma and see if we are right.
So the diagnosis is asthma. The diagnosis is
Mm.
asthma. Although
Oh,
it's
okay.
very,
Then,
it's
Dr.
very, very,
Babali,
it's
sorry,
very, yeah,
is recording going on?
yes, yes, yes.
Okay.
It's very, very unlikely most of the time. Once you say diagnosis being mentioned, it will not really be the answer most of the time. Just like you mentioned, like they told us the person is already asthmatic and you are now picking asthma. But looking at all these features, asthma, is supported because you have ruled out everything what you have said. GERD would have been a very good answer, but they told us the symptoms are not worse during meals or lying down, and that's what you expect for GERD. So asthma is the best, answer to
And
predict.
they also give us the clean child, the nocturia
Yeah,
worsening at night. Usually
exactly.
people have nocturia worsening or early in the morning. Those
Yeah,
two
those
very
two
classic
things.
features for them.
Yeah, yeah, and you see the symptomatology, chest tightness, the cough, shortness of breath. So that's in keeping with asthma. So um, okay, that's very good. Thank you very much for your attempt, Doctor Joy. So let us start, and we are going to start with the physiology, looking at the lung volumes again. I know this is something we already know, so it's not strange to us. Um, we have here the tidal volume, so which is just the minimum amount of air that is exchanged in a single breath. So somebody is breathing quietly, inhaling, exhaling without any effort. That is tidal volume. So looking at it from here to here is your tidal volume. Here is 2.2 liters, here is 2.7. So the difference is 0.5 liters. So it means that volume is 500 mils, right? So you inspire from here to here, you expire 500, you take in 500, take out 500, take in 500, take out 500, take in 500 up to this point. Now, there's something we call the inspiratory reserve volume, which is more like the way I see it, the reserve volume is that those are the allowances that you have. Fine, you can take in 500, you can take out 500. But after you take in 500, you have allowance to take in more. So that allowance is your reserve volume. So if I'm taking in more after I have completed a tidal inspiration, that extra volume I can take in is your inspiratory reserve volume. So look at this patient now, takes in 500, takes out 500, takes in again, takes out an extra volume up till the maximum, which is 6 liters. That's the total lung volume here. So that difference is going to be your inspiratory reserve volume. So that's 2.7 to 6. So the difference is going to be 3.3. Same thing for expiration. So you come down here, normal tidal expiration from here to here. Now you are also expiring beyond your normal capacity. So after you have completed your tidal expiration, you still have more space to expire. Like you can still bring out more air. But mind you, even though you can bring out extra air, there's a certain volume or certain amount of air that will always remain in your lung cavity that cannot come out. And that is your reserve volume. No matter how forceful you are breathing out, your residual volume can never come out. And that is 1.2 liters. It's always there to keep your lung patent so that they don't collapse. They're there. You can't bring them out. So after a tidal expiratory breath, the extra amount of air you can push out is your expiratory reserve volume, and that is from here to here. So that's about 1 liter. Why from here to here is your residual that is always there. That is always there. Now, the sum, just like we remember, the sum of two volume or more volume, maybe 2, 3, 4 volumes, will usually give you a capacity. Your expiratory reserve volume plus residual volume is going to amount to your functional residual capacity, just like we are saying in this arrow. So this is taking out, this is including the sum of the expiratory reserve volume and residual volume. So, which tells us in a way that this is the amount of air that remains in the lung at the end of a normal tidal expiratory breath. Because if you look at it, at this point, this person has completed the normal tidal expiratory breath. So what is remaining from here to here is the functional residual capacity, because the person has not taken out any extra breath beyond the normal tidal expiratory breath. So it's including the expiratory reserve that the person have with the residual volume. That's your functional residual capacity. Now, there's something we also called the vital capacity. So vital capacity just means you take a normal tidal inspiration, then you try to breathe in maximally to fill your lung to maximum. Then you breathe out maximally as well. That's your vital capacity. It means you are taking a normal tidal inspiration, uh, taking a forceful inspiration, which is your IRV, to fill your lung to the maximum, and you breathe out maximally too. What is going to remain in your lung in that situation is your residual volume. So it means vital capacity is going to be the sum of your normal tidal inspiratory volume, which is from here to here, 500. You take in the extra to fill it to maximum from here to here. Then you come down, maximal expiration from here down to this place. So it means that once you know your total lung volume, you just subtract it from your residual volume. You are going to get your vital capacity. Then, of course, from 0 to 6 is your total lung capacity. So that's just to refresh our memory about the volumes and the capacity. So we need to remind ourselves of the spirometry patterns for each of the lung disease, because we know we have obstructive lung disease, we have restrictive lung disease. The simple
Sorry,
way to
Dr.
look at
Sorry, Babawale. Did you say total lung capacity minus is it the functional residual capacity?
no residual volume,
The
residual,
residual.
yeah,
Okay.
that's going to be your vital capacity. Please,
Okay, to
I'm
me.
so sorry. Please, if you have a question, maybe when I get to a point, I'm going to ask us for any question. Maybe you can just note them down so that my train of thought will not be uh disrupted. Please, I'm so sorry. So um we need to know, the differences between the two types of disease, the obstructive and the restrictive. The way to look at it is that the obstructive ones are the diseases that causes obstruction of the airway narrowing, particularly affecting expiration. That is all. Particularly affecting expiration. And we are going to explain. Why the restrictive one, just look at it as conditions that prevent the lungs from expanding and filling with air. Those are the restrictive lung disease. So we should be very, very familiar with the respiratory pattern so that when we read our question, we see the spirometric value, we know what they are talking about, and we move on fast without wasting any time. So we know the different parameters we can get from spirometry. You can extrapolate your functional expiratory volume, your first, sorry, not functional. I make that mistake a lot. I don't know why. I like calling it functional, but it's first expiratory volume in 1 second. That's your FEV1. The amount of air that you can force out into your spirometry tube in 1 second. You know that somebody that is having an obstruction at expiration, the person cannot force out air largely, during the expiratory phase because of that obstruction. So you don't expect the value to be great. And that is what happens in obstructive lung disease. Their FEV1 which is the amount of air that can be forced out during the expiratory phase in 1 second, is going to be low. So it's low. There's something we call the forced vital capacity. So the amount of air that you can take in, maxima, after taking a deep maximal breath and force out, is also going to reduce because it also has some expiratory component. So it's going to drop to the forced vital capacity. Don't forget, the vital capacity is a sum, is derived from the total lung capacity minus residual volume. The vital capacity is also the sum of the inspiratory reserve volume. I didn't show us. I think I said it. I mentioned it. The inspiratory reserve volume, the tidal volume, and what? The expiratory reserve volume. So if you have add all these volumes together, you get your forced vital capacity. But in obstructive lung disease, it can be normal sometimes, and it can also be reduced. What I want us to put at the back of our mind is that the first expiratory volume in 1 second, that is the one that drops the most in obstructive lung disease. That is the one that drops the most because you are just trying to expire in 1 second. That 1 second is not a long time to overcome any form of resistance. So that volume is going to be very small. So it drops usually more than the first vital capacity. Now you have to generate the ratio. The first expiratory volume in 1 second over the first vital capacity. So that ratio is going to be less than a value. What is the value? This value rate 70%. Of course, because we have said it that the first expiratory volume is usually lesser than the first vital capacity in people with obstructive lung disease. So you don't expect the ratio to be big. So it's going to be smaller compared to the reference. And the reference is 70% or 0.7. That's normal, greater than 70%. So people with obstructive lung disease have reduced FEV1, have normal or reduced FVC. They have a reduced FEV1 FVC ratio. What is going to happen to their residuals? The residuals that I'm talking about include the residual volume, the functional residual capacity. Because we have said that there's an obstruction at expiration. It means that hair is not able to get out. It means that hair will be trapped in the airway. That's the physiology. Air is going to be trapped in the airway, and that air trapping is what is causing the problem. And we know that functional residual capacity is talking about the amount of air that remains in the airway at the end of a normal tidal expiratory breath. So, because of the trapping, what's going to happen to FRC in people with obstructive lung disease? It is going to be elevated. What is going to happen to the residual volume that is not here? It is going to be elevated. If residual volume is elevated, if functional residual capacity is elevated, what do we think is going to happen to the total lung capacity? There's going to be more room in the lungs. The total lung capacity is going to be increased. Don't forget, there's a normal range for all these values. They are always within 80 to 120% for the individual's age, the individual's sex, the individual's, race or blah blah. For age, for gender, it should be 80 to 120% of that person's range. That's what it should be, 80 to 120%. Less than 70 is a problem. It is a problem, and it is more in keeping with obstructive lung pattern. Okay, so we are going to talk about the restrictive pattern too. For restrictive, the problem is taking in air initially. And we know that if somebody doesn't have capacity to take in air, do you think the person will even have much air to take out? No. You are not taking in air initially. So which volume of air do you want to be pushing out? So almost everything in restrictive lung disease drops. Everything is low. Amount of air you are pushing out, the expiratory component including your FEV1 and FVC. They are low because you don't even have enough air to take in initially. Your functional residual capacity, your tidal, your residual volume, your total lung capacity is low. You are not taking in anything. But what is not low in restrictive lung disease is what? The ratio of FEV1 and FVC. The ratio is usually normal or increased. Normal or increased. Because in them, the forced vital capacity doesn't usually drop significantly like um, the the forced vital capacity drops more than the FEV1, or as opposed to what you have in obstructive lung disease, in which the FEV1 is one that drops the most. So don't let us forget that. In obstructive lung disease, FEV1 drops the most, but in restrictive lung disease, FVC drops more than FEV1. So the ratio is going to be normal or increased. So once you see a normal or increased lung disease, we can rule out obstructive. In obstructive, we always expect that ratio to be less than 70. So once we get 70 and above, restrictive. 0.69 below, obstructive. Do we understand that, or we have any question there? Do you have any question there? Or is it clear to us? Hello? Are we there?
Okay, but we're giving you thumbs up. It seems you can
Okay,
see the
yeah,
thumbs.
I can't see, the PDF reader. I can't
Mm.
see it's
Oh,
fine. Okay, then looking at the flow volume curve, this curve is very simple. Some people code it, I can't remember what I used in my step one. Maybe I coded it. I can't really remember, but it's something you can code and it's something you can understand if you want to. So this is just talking about the flow and the volume relationship. Flow is volume per time, liter per second. The rate at which we are moving out here, we are plotting it against the lung volumes. So on your y-axis, you have your flow rate, and on your x-axis, you have your volume. So this is the normal. This is what you expect normally. This individual's total lung volume is starting from here, because you can see the volume chart is moving from 0 to 8. So from here to here is this individual's total lung volume, and that's about, let's say, 6 liters now. Now, the curve that is up, that is talking about the expiratory component. You can see here, expiration, and the curve that is below is the inspiratory component. So, during expiration, we tell the individual to breathe out, using your spirometer. You also get this curve from your spirometry reading. That's how you can plot this. So, try to breathe out, first. Initially, the flow rate is going to be high. So hence you get this peak from 0 to 8. Then later, that force will drop. Then as the force is dropping, the volume in the lung is going to reduce because the person is expiring. So the initial rate at which the person is moving out the air, is very high at about 8 liter per second. That is the peak, flow rate. Then, because the person is losing air, the volume is going to drop. So it's dropping from 6 to this value. So let's assume this value is 1.2, which is your residual volume. This is the volume that remains in the lung. So from here to here is the volume that remains in the lung, because you cannot breathe out beyond this volume. That's your residual volume. So, that is that. Then during inspiration, the person also tries to breathe in, forcefully, at a particular flow rate, which is going to peak suddenly from here to about, let's say, 5 liter per second. And because you are taking in air at that point, you are going to have an increase in the lung volume, up to maximum. So from here, from residual, we are going to top it up to your total lung capacity. So it means from here to here is your vital capacity. because we already said it. Here to here is residual volume. Here to here is total lung capacity. So it means that if you subtract uh, residual from total lung capacity, you are left with a vital capacity. So that means from here to here is your vital capacity. So that should, be the normal pattern. When people with obstructive lung disease, we remember that we said they usually have an increase in their residual volume. They have an increase in the total lung capacity. Number one, because of the fact that there's air trapping, because not all the volume of air is escaping from the lungs during expiration, because there's an obstruction during expiration, particularly, and you cannot take out all the air. So some volumes are still trapped. The residual volume is increased. You know, so that means the residual volume is not going to be starting at this point, which is the normal point. It's going to be starting at a higher value. Hence, you see this curve shifting to the left because it's moving towards a larger volume. So from 0 to about, let's say 3 point something here, 3.4 or so. So here to here is the residual volume. It means that the residual volume has actually increased. The person tries to take in air during inspiration, increase flow rate, increase, then the flow rate reduces as the person calms down. The initial, then the subsequent, calmness, relaxation is what is bringing down the flow rate. Then at the end of the day, you achieve an increase in volume from here to here. But you notice that from here to here, the vital capacity, if you add it to the residual volume, is going to increase the total lung capacity too, because your what's it called, residual volume contributes to your total lung capacity. So if residual is increased, your vital capacity, your total lung volume too will be increased. So that's why it's moving beyond 6 and it's going towards 8 point something. So everything is increasing. But most importantly, aside that, what you look out for in obstructive is the coughing of this expiratory breath, and at the same time, a reduction in the peak of expiration. Because when they try to breathe out, they don't breathe out at a very increased flow rate because of that obstruction. It will impede, the way resistance in the flow rate. So it's not going to shoot up like normal 8 liter. It's not going to get to 8 liter because of the obstruction when the person wants to breathe out. The person is going to encounter that obstruction. So the peak flow rate is not going to be high, so it's going to drop. And when the person is now exhaling in the relaxation phase, the person is going to you are going to notice that resistance, hence the bending of that expiration phase. You can see here, there's no bending, there's no resistance, smooth. But in obstructive, you will notice a reduction in the peak expiratory flow rate, and at the same time, an indentation in the flow curve due to the resistance encountered. So it goes to the left. Why for restrictive? Because that is having R as a starting letter, it goes to the right. So we remember that everything about restrictive is reduction. Reduction total lung volume, reduction in vital capacity, reduction in residual volume. So it means that we are going to be starting the residual volume very close to 0. So we can see here that the curve is shifting towards the right. This person's residual volume now is between 0 to this value. So, and we know that restrictive is more of a problem of initial inspiration. The person cannot even take in air. So what do you expect? The inspiratory peak volume, is going to, the peak flow rate rather, is going to reduce compared to normal. Look at normal, about 5. Look at this guy's one, about maybe 2, because of difficulty in the lung expanding. Maybe this person has pulmonary fibrosis, has kyphoscoliosis, have interstitial lung disease of any kind. Person cannot take it here. So that peak is going to drop. And at the end of the day, the amount of volume the person is going to take in, is going to be very reduced. So the vital capacity also drops. So you can see it's not, as high as this one, which is about total lung volume of 6. Here it's just 4. So, and you notice that you don't have much reduction in the expiratory flow, because you have reduction, yeah, but it's not going to be very significant. So yeah, it's like about 5 or 6. So you have more drop in the inspiratory than the expiratory. And of course, it lacks that indentation in the expiratory phase. So those are the features of the restrictive flow pattern. So do we have any question? I think that's clear to us. So we should be very conversant with the ratio. We should not forget it. When the ratio is less than 70, it is in keeping with obstructive lung disease. When it is equal to or greater than 70, that's in keeping with um, restrictive lung disease. So what are the examples of the obstructive lung disease to know? Just about 4 of them: asthma, COPD, cystic fibrosis, bronchiectasis. But here, I think maybe in the pediatric section, we'll be covering cystic fibrosis there. So, but here, majorly focusing on asthma, bronchiectasis, and COPD for the obstructive component. While for the restrictive, there are plenty. So, interstitial lung disease majorly, we talk about interstitial lung disease majorly, neuromuscular, obesity, scoliosis, anything that impedes the lung from expanding adequately, anything that impedes that normal excutatory expansion of the lungs brings about the restrictive pattern. So don't forget, the ratio is going to be normal or greater than 70. So just like I've said, apical, asthma, bronchiectasis, COPD, or cystic fibrosis, and also obstruction, maybe from foreign body or from some webs, lesions in the tracheal or the bronchus. So moving on to asthma. So we are starting with asthma. One of the major common obstructive lung disease pattern. We already know that asthma is a genetic disease. So there's a genetic component to it, which kind of makes the airway hyper-responsive. It makes the airway hyper-reactive to innocuous, normally innocuous stimulus, like pollen, like dust, like mites, like cold air, something that don't trigger much, bronchial reaction in a normal individual. But in individuals with asthma, they have an increased bronchial responsiveness, such that once they are exposed to any of the trigger, there is an inflammatory response. So what are the basic cells that are involved in this inflammatory response? So you have your eosinophils and your mast cells particularly. So, and what do they do? The mast cells are going to degranulate, releasing two major uh, components, which we must remember: histamine and leukotriene. So this is not interleukin 1, this is not gamma interferon, but histamine and leukotriene. So when they degranulate, they release these guys. And what are they going to do? They are going to trigger depolarization of the smooth muscle of the airway. So when the muscle depolarizes, it contracts and it becomes bigger. So hence causing the smooth muscle hypertrophy. And at the same time, they also have stimulatory effect on the mucous cells of the airway, which are the goblet cells, allowing them to secrete more mucus. So you're going to have mucus plugging. So the combination of the bronchial hyperreactivity, airway inflammation, the mucus plugging, and the smooth muscle hypertrophy, all from the effect of histamine, leukotriene, and genetics working together, brings about narrowing of the airway, particularly during expiration. Don't forget, if somebody is taking in air, the person is using muscle. Inspiration is an active process, but expiration is not an active process. Expiration is usually passive. You are just banking on the elastic recoil of the lung. We are going to talk about that elastic recoil because we have to understand it to understand what is going on in COPD. So during expiration, we are just banking on the elastic recoil of the lung coming together to generate an upward force to move out here. So nothing is assisted. So if you are not having any form of obstruction, which phase do you think will be problematic? The one that you are not having any support from any muscle, the expiratory phase. So that is one thing to keep in mind. Asthma usually get diagnosed in childhood, but sometimes you can have early, adulthood, like maybe following pregnancy, Maybe some people, occupational asthma after they start working. Some people, maybe when they grow up and they get obese. Obesity, is a very significant risk factor for GERD. And GERD is no friend to asthma. GERD is one of the triggers, is one of the comorbidities of asthma. So, childhood and early adulthood. So, it's important for us to remember that all that wheeze is not asthma, because one of the cardinal symptoms of asthma that we remember is what? Wheezing. Very common in people with asthma, but it is not only asthma that causes. It is not only asthma that causes wheezing. Anything that causes obstruction of the airway, narrowing of the airway, because wheezing. So a small child that has foreign body dislodged into the airway can wheeze. Someone that has obstruction, but not from asthma, but from COPD, can wheeze. Someone that have heart failure, fluid in the heart, in the airways too, can wheeze, but their own wheezing is called cardiac wheezing. So how do they present? We need to remember those symptoms. I'm sure we know them already. So they are going to have dry cough. They have episodic time to time wheezing, difficulty in breathing, and chest tightness. So somebody is coughing, having the breathing is not normal, experiencing difficulty in breathing and holding on to the chest. My chest is tight. That's asthma you are tilting towards. These four symptoms, the cough, the wheezing, the dyspnea, and the chest tightness, usually occur maybe at night or very early in the morning, because in this condition you have cold hair, and cold hair is one of the trigger for asthma. Cold hair is one of the trigger for asthma, and it reminds me of exercise-induced bronchoconstriction that we are going to talk about. Exercise-induced bronchoconstriction. It's due to this cold hair. It's related to this cold hair of a thing, which I'm going to talk about later. So, and also when you lie down, it can, allow for mucus accumulation, and you can easily have the symptom. So, if you inspect or examine somebody with asthma, what are the key findings that we are typically going to see? We remember that when you are examining a patient, you might want to observe, you feel, you percuss, then you listen. So when we are looking at the patient, definitely the person is going to be in respiratory distress, dyspnea. So the person might be using the accessory muscles. So the person using the intercostals, using um, the serratus anterior latissimus, even the sternocleidomastoid, accessory muscles to breathe. This person is not normal. If you observe the person, you will notice that the expiratory phase is going to be prolonged compared to the inspiratory phase, because the obstruction is impeding on expiration. So the person will want to take more time in expiration. So when the person is breathing out, it's going to take more time, it's going to be delayed than inspiration. So very important. Once you see the question saying prolonged expiration, you know that okay, this is likely to be one of the obstructive disease they are talking about. The person is having accessory muscle usage, prolonged expiration. And when there's prolonged expiration, what do you think will happen to the inspiratory-expiratory ratio? It's going to drop, because the person is going to spend more time in expiration than inspiration. When you listen, you hear the typical wheezing, the wrong kind, and if you percuss on that chest because of air trapping, remember, air is accumulating within the chambers of the lung. They cannot go out during expiration. They are trapped within the lung. So there's going to be hyperlucency. There's going to be air trapping. So the alveoli, they are going to be distended with a lot of air. And when you percuss, you are going to observe hyperresonance, percussion notes. So those are the things I want us to really pay attention to, of course. And of course, the person is going to be tachypneic, because the person is trying to bring in more air by increasing the respiratory rate, which might not really help the person. It will not help the person. So, and I'm going to explain that a bit later when we go down in the lecture. So the person is going to be tachypneic, And that is one of the reasons why you observe that people with asthma experience respiratory alkalosis because they are trying to breathe out fast. And at the end of the day, they take out all the CO2 and they become alkalotic due to respiratory effects. They're tachycardic, they're trying to increase the heart rate so that they can pump more blood to the tissues and deliver more oxygen to try to compensate or take care of the hypoxemia, which is not going to do anything. So now this is where we need to now pay attention because most of the questions focuses on severity of the disease. Severe disease. That is what they like asking. Because you must be able to recognize the cardinal signs of severe disease of asthma when it's getting worse. The first thing is you noticing reduction in the breath sounds or the chest becoming silent. Somebody having asthma, you are listening to the chest and you cannot hear the typical wheezing the person is going gradually because it means the respiratory muscles are getting fatigued, the airway is totally becoming blocked, that there's no passage for air to even go in or go out again. Reduction in the breath sound or silent chest. Silent chest. You are going to notice hypoxemia, drop in the oxygen concentration or saturation, usually less than 50. When it's getting less than 50, there's a problem. Or hypercapnia. The person normally should have hyperventilatory response. But when the respiratory muscles are getting tired, the obstruction is getting total. The person cannot even bring out CO2 again. So you are seeing hypercapnia in a patient with asthma. That's problem. That is problem. Usually value greater than 50. You can see that it is easy. Oxygen less than 50, hypoxemia. CO2 less greater than 50, hypercapnia. They both of them with silent chest, they are cardinal signs of severe disease. Then lastly, you don't want to forget about pulsus paradoxicus. You don't need to think too far of why people with asthma experiences pulsus paradoxicus. We already know that pulsus paradoxicus is when you have drop in the systolic blood pressure of more than 10 millimeter of mercury during inspiratory phase. So what is causing this in people with asthma that is becoming severe? Two things to just note. Number one, we know that in asthma there is airway trapping. There's an increase in the intrathoracic pressure because of that airway trapping. We remember that the pulmonary vein is what delivers blood to the left side of the heart. So that increased intrathoracic pressure is going to be compressing on that pulmonary vein, reducing the preload to the left atrium and the left ventricle, and is going to drop the output from the aorta. Now, this is now going to be worsened in inspiration again, because in inspiration, you have more blood flow to the right side more than the left. So we are going to have more worsened drop in the systolic blood pressure in asthma in people with severe form because of what I've said. You know, that trapping now for that kinking on the pulmonary vein, reducing delivery to the aorta. That's number one. Number two is that when you have asthma, increase in intrathoracic pressure, airway trapping, there's a form of mediastinal shift. You remember that the lungs, are just in between, they are just at the side of the mediastinum. So when they become bigger, what do we think it's going to be happening to the mediastinal structure? They will try to be compressing them in between. So it will compress on the left ventricle, the right ventricle. But it is the left ventricle that will suffer more because during inspiration, normally there's reduction in blood flow to the left ventricle. You are now also kinking it again. What do you think will happen to the volume that is, going out of left ventricle? It's going to drop. So that brings about the pulsus paradoxicus. And this pressure can only increase when the degree of the airway trapping is getting severe. So that's when the intrathoracic pressure can now be big to be compressing on the heart and also kinking the pulmonary vein, causing pulsus paradoxicus. Same thing with individual with COPD. The same pathophysiology. Don't forget. So you might want to rescue them either by giving them a non-invasive positive pressure ventilation using a BiPAP machine, or you want to place them on a mechanical ventilator. Don't worry about that. We are going to talk about them when we get there. So, asthma should be suspected in children with multiple episodes of croup and upper respiratory tract infection. So, you have a child that is recurrently presented with inspiratory stridor, hoarseness of voice, difficulty in breathing, and you are thinking of croup or maybe upper respiratory tract infection, everything time to time. Now, there's an impending asthma happening in those children because this recurrent inflammation from all these infections will heighten the response of the bronchial airways to normal stimulus, because recurrent infection can also be a trigger for asthma. So you should keep that in mind. And also you expect asthma to be more pronounced or more common in people with some allergic disease, allergic dermatitis, eczema. So you have a child having allergic rhinitis, always scratching the nose, always scratching the eyes, having some skin lesions, in keeping with eczema, that there's a tendency of that child to be atopic and they can also develop asthma. So don't forget, recurrent respiratory tract infection, people with skin infection like dermatitis, they can have asthma. So what are the asthma triggers? Very easy. We know these things. Allergen, pollen grain, mold, dust, mite, recurrent upper respiratory tract infection, cold hair. Why? Because cold hair, just like I have here, so that I don't forget, they kind of overwhelm the eating and the humidification mechanism of the lung. Let me explain. Cold air and exercise go together. When somebody is exercising, there's an increase in the minute ventilation. To remind us, minute ventilation is a product of tidal volume and respiratory rate. During exercise, you need to take in more air so that you can deliver more oxygen to the actively contracting muscles. So you need to hyperventilate. Then also the volume of air that you'll be taking in might be large, your tidal volume. So increasing the minute ventilation. This is going to be bombarding the heating and the humidification parameters, or the machinery rather, of the airway, the upper airway, because that is what they do. That's why we have normal physiology dead space, because the initial air that you are taking in will just be, cooled, by your, what's it called, upper airway. They're just being kept warm and, what's it called, heated. So they are being heated and they are kept moist, by the upper airway. That's what they do, so that you don't have any allergic trigger whatsoever. But when you are taking too much air at the same time, too much volume is going to bombard this mechanism, so they are not able to eat them adequately. So when you are not able to eat the air adequately, it means that that air is going to be cold or cool. And if you are not able to humidify them, that is, you are not able to moisten them, they are going to appear dry. So dry and cool or cold air triggers mast cells degradation, kicking off the pathophysiology of asthma. So you start having your degradation, your inflammation, goblet secretion, smooth muscle hypertrophy, bronchoconstriction, and asthmatic episodes. Very, very important. So that is the pathophysiology of exercise-induced bronchoconstriction. So what do you want to do for these individuals? Because this is an opportunity to talk about it. I might not talk about it when we get to the normal treatment. So what you want to do is that if the person has background asthma and the person is experiencing exercise-induced bronchoconstriction, you might want to step up the asthma therapy. We are going to talk about it later. You step up your asthma therapy. So I'm going to show us the algorithm. Or after you have done that and the person doesn't improve, you can pre-medicate. What do you give? You give LABA plus your ICS, your inhaled corticosteroid plus your long-acting beta agonist. you give it 10 minutes prior to the onset of the exercise so that you can suppress the bronchoconstriction and also the inflammatory response. Or you can give your glucotriene receptor antagonist like your montelukast 2 hours prior to the exercise. We're going to look at some questions. Up, up. Dr. Lushola, please remind me in case I forget. Questions are up. When we are done with the asthma, we're going to look at the questions. So that's code here, that's exercise. Both of them, they work together. Then some medications. Aspirin. We are going to talk about aspirin exacerbated respiratory disease. Aspirin is an NSAID, so they go together. Beta blockers. We already know that beta blockers, particularly the non-selective ones that block the beta 2 receptors, can cause bronchoconstriction because when you stimulate the beta 2 receptors, the airway dilates, bronchodilation. But when you block it, it constricts. So that's why you don't give people with asthma beta blockers. We have killed the patient. So stress in adults and children too can cause asthma. And most importantly, I put it here, GERD. So people that are obese, they can also have asthma because of GERD. So obesity kind of affect the integrity of the lower esophageal sphincter, and you can easily have reflux of gastric content into the airway, and this gastric content can easily trigger the bronchial constriction, and they can have signs and symptoms of asthma. So what is going to tilt your mind towards GERD is that they will tell us that the symptoms get usually worsened maybe after meals, and of course the person experiences some sore throat due to that reflux, going to uh, the passing through the pharynx down to the airway, so it can cause irritation of pharynx, speaking about sore throat. And when the person wakes up in the morning and person wants to talk, there'll be hoarseness. Those can, because asthma is not going to cause this. So once you see this in a person, having the symptoms maybe after meal, after lying down at night, because when you are lying down, you are kind of moving up against gravity, and you can easily have the gastric content going up. So, and the person wakes up, experience sore throat, hoarseness in the morning, GERD. Think of GERD. So that's why in some people, you might want to give them PPI to take care of the GERD before you can now finally take care of the asthma. We are going to talk about different asthma phenotypes. So we need to have that at the back of our mind. Aspirin exacerbated respiratory disease has been tested in our step 1. I'm sure we already know the SAMSTAR triad. Very easy. Just 3 things. So asthma, number 1. Number 2, chronic rhinosinusitis with nasal polyps. Very important stuff. And intolerance to aspirin. Hypersensitivity to aspirin, reaction to aspirin, or any NSAIDs. So those 3 things at the back of our mind: asthma, chronic rhinosinusitis with nasal polyps, and intolerance to NSAIDs, including aspirin. How does it start? Number 1, this is not a typical allergic reaction. It is not IgE mediated. So what is now mediating this guy? What happens is that when you use NSAIDs or aspirin, we remember that everything starts from arachidonic acid, right? Arachidonic acid, we have our cyclooxygenase acting on arachidonic acid, converting into our prostaglandin derivative. We also have another pathway, which is the lipooxygenase pathway. The lipooxygenase pathway is responsible for forming our leukotrienes, right? If somebody is using NSAID or using aspirin, that is going to block the cyclooxygenase pathway. That's what they do, COX-1 and 2 blockers. Now, it means that all the arachidonic acid is going to be made available for lipooxygenase to use. So you have a lot of lipooxygenase activity converting our arachidonic acid to leukotrienes. So you have a lot of leukotrienes in abundance. And don't forget the 2 mediators that we talked about that induces asthma: histamine and leukotriene. So leukotriene kicks on the process leading to asthma. But what they because these leukotrienes are inflammatory mediators, so they might not start with asthma. They might start with rhinosinusitis. Initially, that's what the person is going to start with. So you start noticing that the person is having recurrent nasal drainage, recurrent nasal congestion, recurrent headache, recurrent facial pain. You know that the sinuses are located within the facial compartment. So rhino, nose, sinus in the sinus, recurrent nasal discharge, nasal congestion. Person is always complaining of blocked nose. It is the leukotriene doing its work. Then later it gets to the lower airways, causing asthma. And don't forget, because one of the triggers for nasal polyps is what? Recurrent rhinosinusitis. When you have recurrent inflammatory reaction in the nasal mucosa, the sinus mucosa, you try to have outpouching of that mucosa as polyps. Cystic fibrosis is a very common cause of nasal polyps. Aspirin exacerbated respiratory disease is another secondary cause that we need to remember. So afterwards, the person will start developing asthmatic symptoms. And lastly, the person will now start showing intolerance to the aspirin. What do they mean by this intolerance to NSAID aspirin? The person will start developing some rash, urticaria rash. Some people can have angioedema. Some people can have abdominal symptoms, just abdominal pain, vomiting, diarrhea. So some people can even proceed to have hypotension. So all these things are driven by the inflammatory mediators, leukotriene, causing the problem. It is not IgE mediated. Don't be tempted to pick in IgE. So you can give them internal. I have the treatment here in case you are asked. Intranasal corticosteroid to suppress that inflammatory drive. Because everything starts from aspirin use. And of course, you cannot say that somebody will not use aspirin if the person is needing aspirin. So you want to do the process of aspirin desensitization. So you just keep exposing them to small doses of aspirin, then you increase it with time. With time, they will get used to the aspirin and they will be desensitized. So you can use some biologics, leukotriene receptor, what's it called, blockers, montelukast and the likes, biologics. And if there's a need, the polyps is getting too much, you can do functional endoscopic sinus surgery to remove the polyps. That is all about aspirin exacerbated respiratory disease. Very important stuff we need to remember. Remember the cardinal symptoms: asthma, cardiorhinosinusitis, chronic rhinosinusitis with nasal polyps, intolerance to aspirin. The symptoms, particularly the intolerance symptoms, and the fact that it is mediated by leukotriene and not by IgE. Very, very important. So there's a statement here: the physician should suspect impending respiratory failure in a patient with severe asthma exacerbation and in normal or normalizing CO2 concentration and pH. Very important stuff. I have said it here that remember the initial drive is hyperventilation in asthma. So somebody having an acute episode of asthmatic attack, the person is hyperventilating and the concentration of CO2 in the blood should drop. But where you know that there's a problem is when that person lacks that hyperventilation drive. The person is no longer and the person is now person is having respiratory fatigue, severe obstruction. Nothing, the person cannot can again. If there's a word like that, the person cannot can again. So what do you think will happen to the PCO2 that is initially reduced? Because of the fact that the person cannot can again with the breathing mechanism, CO2 will keep building up. So it depends on the stage where you catch it. It can be normal or it can be elevated. So at the early phase, it will be normal. At the late phase, it will be elevated. So some people will see PCO2 level that is normal. They will think, we are doing well. whereas they are playing. So they are not doing well, but you rather need to give an urgent ventilating support to that patient, or else that patient is going to die. So watch out. Normalizing PCO2 or increased PCO2 is a sign of impeding respiratory failure. In fact, if it has even increased, the respiratory apparatus are failed already. So the word impeding here is, in keeping with this normal stuff. So if it's getting normal, it means that it's already failing. But by the time it increased, it has failed. So there's an urgent need for your mechanical ventilation. You are going to come across a lot of questions testing this phenomenon. So it's highly, very, very important. So we want to make a diagnosis of an individual with asthma. What are we going to do? We do our pulmonary function test in form of spirometry. Spirometry is a gold standard. That's the best initial test. That is the best initial test to do. And we are looking for the obstructive pattern with response to what? To SABA. Very, very important. People don't remember this. You are doing your test with administration of drugs, and you expect your spirometric pattern to be reversed once you give SABA, because asthma is different from COPD in that asthma is reversible. COPD is nearly irreversible or irreversible. You won't see any significant change. You might see improvement, but it will not be significant. There's a value, there's a reference. There's a reference. So, asthma is an obstructive lung disease that is reversible when you administer your SABA, your short-acting beta-2 agonists like albuterol, like your terbutaline, whatever the likes we are giving. So, we do a baseline spirometry test. We measure the FEV1 baseline, the FVC baseline. We calculate the ratio. Definitely, we are going to get a value less than 70% if the person is truly asthmatic. Mind you, in some situations, it can be normal. We're going to talk about it. What do you do next? You now administer your SABA. You wait for some time. You repeat the test. You will notice that there will be an improvement in the lung parameter. The FEV1 is going to show a difference of more than 12% increase, either in percentage or in volume. So it's going to increase by 12% from baseline, or by 200 mils from baseline after you administer your SABA. Don't forget that. Do not ever forget that. The way I remember it is that I know that 12 and 200 is your working value for improvement. But when it is getting worse, I will tell us what I mean by when it's getting worse. When it is getting worse, the value is 20%. When it is getting improved, the value is 12%. So improved 12%, 200 mils. Getting worse, 20%. So what are the other things that is going to be affected? People with asthma. We already know that their residual volume increases, FRC increases, total lung capacity increases. And what again? Diffusing capacity for carbon monoxide. We already know this guy. We are familiar with this guy from our step 1. Diffusing capacity for lungs. In asthma, don't be surprised. It can be normal, but it can be increased. It can be normal, or it can be increased. It can be increased because asthma with time, particularly at the late stage of asthma, it will have caused so much inflammatory damage to the extent that your body will try to recruit more pulmonary capillaries. And we know that the higher the amount of blood that you have within that area, the more diffusing capacity for your carbon monoxide. So that's why pulmonary hemorrhage can cause increased DLCO. When you have a lot of blood within your alveoli, or you have recruitment of massive amount of your pulmonary capillaries, they can increase your DLCO for asthma. So asthma is the only obstructive lung disease that increases your DLCO. COPD, depending on the phenotype, if it's chronic bronchitis that is only obstructing the airway, by mucous obstruction, it should be normal. But if there's damage to the alveolar capillary membrane, like in emphysema, your DLCO will drop. I'm going to emphasize that when I get to that portion. Just follow me, just as we move. So, in some people, between exacerbation, you notice that if you do this spirometry, it will be normal. You do your baseline is more than 70, your reversibility self improvement. Okay, you don't know, is this asthma? You are confused. So what you do in that situation is you do your metacholine challenge test. That's the best next step after your initial step of spirometry that is inconclusive. You do your metacholine challenge test. Your metacholine is more like this cholinergic agent that stimulates the M3 receptors in your airway, and then they contract the airways. So you do the value, you do your ratio at baseline, then you also repeat after you administer your metacholine. So because of the bronchoconstriction that's been triggered by this metacholine, you will notice a decrease in your FEV, by a value of more than 20% decrease. So this is what I mean by worsening. So when it's improving, 12,200. Worsening, 20% decrease, 20% decrease, 20% decrease. Now, for exercise-induced bronchoconstriction, when you do spirometry for them, they have worsening, you know, uh, value of more than 15. So you do it at baseline before exercising. You repeat after exercising, you notice a decrease by 15. But for metacholine, it is 200. It is 20%. For normal asthma, using your SABA improvement, it is 12% and 200 mils. Please, hope I'm communicating, my people. Are you following what I'm saying? Is there any area that is confusing?
Yes, I'm following, but we have some questions.
Oh, Dr. Antonia, please,
Mm,
before I go too far. So
okay. So I don't want to forget. Okay.
I'm with you, Dr. Antonia. So is it here or where? Let's start from.
Is the I didn't get what you're explaining with the exercise induced and the and the cold air as triggers
Okay.
for asthma attack. Yeah.
What I was saying there is that that I said that during exercise there's an increase in the minute ventilation. Minute ventilation is product of tidal volume and respiratory rate. Those are the two components that gives your ventilation. Exercising, respiratory rate increase, tidal volume wants to increase ventilation so that I can supply more air. But what happens is that the volume of air that we are taking in per time is more than normal. There are some apparatus within the nose that helps to eat the air that we are taking in. Normally, that's what they do. They eat that air, they prevent it from getting cool and cold. And they also humidify the air. They add water to it, moisten it so that it doesn't become dry. Because trigger for that heightens bronchial hyperresponsiveness is what? Dry hair or cold hair. So exercise, you are taking a large volume at once, so you have overwhelmed that humidification, that eating mechanism of the airway. So definitely you are going to notice that some of the hair that is going to go down is not going to be moist. It is not going to be heated. They are going to be cold or cool and dry. Dry and cool hair triggers degranulation of mast cells immediately, leading to asthma. Dr. Antonia, do you understand that?
I understand you.
Okay. So what else again?
So no, I picked up. So it's for the it's for the boat, right? Both causes mast cell degranulation that
Which one?
triggers the asthma attack.
Yes, yes,
Both for the cold and exercise induced.
exactly, exactly.
Okay.
Yeah. Okay.
Question is, when you were talking to us about the DLOC, that's the diffuse capacity of the lung for carbon monoxide.
Yes.
You, you were explaining about, the impact of asthma, especially when it's very, very chronic, causing pulmonary capillaries, and that's in a way kind of increasing the DLCO.
Yes.
So, but I don't know. I knew you said some things in between that place, but I didn't get it.
Uh,
Though I
I
know at the end of the day, it's the only one that causes increased DLOC. But you were speaking about the pathophysiology behind what increases the DLOC, but I didn't really get it.
yes, it's
And the
just
second question I have
okay.
is, you know, about the obstructive. When you were showing us the graph for
Yes.
the obstructive and then the restrictive pathway. I mean, what's it called? I mean, the explanation.
Okay.
Um, yes. So you mentioned some things there, especially about under the obstructive, that it is more of respiratory. I mean, it's more of expiratory issue.
Yes, yes, I did that.
Yeah, you said it's more of an expiratory issue.
Yes.
But when you look at it in the explanation for respiratory also is more of expiratory issue.
Which one? Is it
But
restrictive?
I mean for restrictive
Yes,
also
yes,
because with
definitely.
restrictive,
Mm-hmm.
yes, the hair is not going out.
Yes,
But I just can't pull together
that works.
how
You
you
know,
now different it.
that I made a statement, ma. I said when somebody has restrictive lung disease, the person cannot take in air initially. It is the volume of air that you taking in that will determine the volume of air that will take out. So imagine that somebody is taking in 10 and another person is taking in 20. The person that is taking in 10 has a restrictive lung disease. What do we think will happen to the amount of air they are going to be taking out? The amount of air that the person that takes in 10, the amount of air the person will take out is going to be less than the amount of air the person that takes in 20. So definitely what happens to the inspiration will definitely affect expiration. But majority of the affectation lies in the inspiratory component for restrictive lung disease. Dr. Rati, do you get that?
Okay. Yes, I'm listening. Okay.
So, but what you just look out for to quickly differentiate them is just to go to the expiratory phase and look for that indentation. So once you see that kinking in that graph, you know that this is obstructive. And of course, it's going to be shifted to the left because the volumes are going to be increased in obstructive. While in restrictive, you won't see that kinking. You will notice a decrease in the inspiratory peak compared to normal. The expiratory peak too will be, decreased because of the fact that what happens to inspiration affects, sorry, what am I saying?
I was like, it's the opposite side. I
Yeah,
mean, it's the
sorry,
opposite.
I wasn't showing my cursor well. So this is
Yeah.
the inspiratory peak. You can see that the inspiratory peak drops more than the expiratory peak, the expiratory
Yeah.
peak. So,
Yeah.
but the expiratory peak also drops compared to normal. But
Yes.
the rate at which inspiratory drops is more than the expiratory peak. And the reason why expiratory peaks drop is because since you are taking in little air, that's going to affect the amount of air that you are going to take out too. So that's
Mm.
why, the expiratory peaks also drops in restrictive.
Okay.
So that's why everything reduces in restrictive. The
Mm-hmm.
expiratory component, FEV1, FVC, as well as your inspiratory component, the one that determines the amount of air that you have in your lungs, like residual, volume, your total lung capacity, your uh what's it called, vital capacity, everything is going to drop in restrictive because you are not even taking in anything initially.
Okay. So you now mentioned that kink again. Please, can you explain the kink?
So this kinking is
Kinking.
this
Yes.
this is what I mean. Is due to
Mm,
the obstruction at her expiration. So that is what is causing this kink. That increased resistance,
oh,
particularly when you are not making any effort. You notice that
oh.
initially this person is making effort, like
Mhm.
trying to breathe out. That is what is causing this sharp rise. But at this point, the flow rate is reducing because this person is now calming down.
Okay.
So taking out the hair, taking it out to residual volume. So and you know that at that point where the person is, you have more tendency to encounter the resistance because
Okay.
at the point that you are trying to initially take it out, there's some force. So you might not encounter that resistance. You can overcome it. But when you are now relaxed, the resistance is going to be there.
Okay.
So that is that.
That,
Then okay, I'm with you. I'm with you.
I said that is clear. Thank you so much, sir.
Yeah, welcome.
So, sir, the other one, the DLCO.
Yes. So that's DLCO one is just you are recruiting more pulmonary capillaries, making more blood available to receive the carbon monoxide. That's just it. So
Okay.
you are just making more blood available to receive the carbon monoxide. So that is just you have more capillaries available, to allow the carbon monoxide diffuse across the alveoli into the blood. So the more the capillary, the more the alveolar capillary respiratory interface, the more diffusion. Don't forget, don't let me I don't want to say this statement, but I'm going to say it so that I don't give people stoof. One thing about DSO is that we know that carbon monoxide is not uh, perfusion limited. Do we remember that stuff? It's not perfusion limited, it is diffusion limited. So that is why when you uh, increase that capillary number, you are kind of at the same time increasing the respiratory membrane interface because that interface is formed between the alveoli and the capillaries. The more the capillaries, the more the interface, the more the diffusion. So that's why there's more DLCO. So that is that, Dr. Lority. Do we understand? But the reason
Yes.
why the reason why it increases in people with pulmonary hemorrhage is because you have a lot of blood already hemorrhaging into the alveoli. And we know something about carbon monoxide. Carbon monoxide, you know, likes hemoglobin like crazy, like 300 or 400 affinity compared to oxygen. So they will be mopping up that carbon monoxide, they're just taking it, and you have a lot of carbon monoxide readily diffusing across into the lungs. So that is why pulmonary hemorrhage in people with Wegener's, people with good posture, can have increased DLCO. So let's just have that at the back of our mind. Pulmonary hemorrhage, increased DLCO. Asthma, increased DLCO. Obesity too can increase DLCO. But the pathophysiology of obesity one, it's in a way linked to recruitment of pulmonary vessels too. We are increasing the blood flow. We are increasing the number of capillaries in people that are obese too. But don't let us go too far. Let's just stick with the pulmonary hemorrhage and the late asthma. That will be fine for the case of sake of our exams.
Dr. Bawale, you mentioned something about, sorry, just one question.
Yeah.
You mentioned about the severity having about 20% decrease in FEV. Then you said something about the exercise on 15%. What was that?
Yeah. So I was trying to explain how you can make diagnosis of
If something,
exercise-induced
okay,
bronchoconstriction.
okay,
So
okay, okay.
what you do is you do it baseline before exercising. Then after the person exercise, you repeat it. You notice that. So it's not like you expect it to be more less than to be decreased than more than 20%. No, the threshold is 15. So once it's greater than 15, you can say that this person has exercise-induced bronchoconstriction. The normal stuff should be less than 10. So
Mm-hmm.
if I exercise now and you do my spirometry, you are going to get the ratio decreasing by up to 10% from baseline. But once it crosses over to 15 beyond, that is exercise induced bronchoconstriction. So
Decreasing, not increasing, right?
increasing, yeah, increasing.
Okay, thank you.
Yeah. No, no, no.
And
So what am I saying? Decreasing, no, Dr.
Yeah, that's why I was confused because you said increasing before, now it's decrease. Okay, so decreasing of 15%.
yes,
All
decreasing.
right,
So
and the FEV 1 minute, right?
yeah,
Yeah.
exactly.
Okay, thank you.
You're welcome. Dr.
then,
Bernard?
sorry, Dr. Bubala. So, when you were saying something about, you said asthma, at less stage of asthma can cause decrease in DLCO,
No,
decrease
increase.
definitely
Increase.
at the less stage.
Yes, increase in DLCO
Okay.
because of
So, how?
recruitment because of the recruitment of pulmonary capillaries. You are
Mhm,
increasing the alveoli capillary membrane, which is the respiratory
mhm,
membrane.
mhm.
Then there's enough room for carbon monoxide to diffuse into the patient.
Okay.
So that
Okay.
is that.
As it ends in the early stage.
In the early stage, it is normal.
Okay.
It is normal. It is not reduced. Please don't pick reduced. So um so so how's the arterial blood gas picture? I know that in our normal laboratory we don't do ABG, but we need to know um, the picture. So in early exacerbation, because of the hyperventilatory response, they have respiratory alkalosis. They're taking out all the CO2. So PCO2 drops, pH is going to what? Increase. That's what you expect. But when it gets, later stage and the person is already having impending respiratory failure, respiratory muscle fatigue, person cannot hyperventilate again, PCO2 will start normalizing, pH will start normalizing, and later they will what? Increase. And don't forget, and of course, oxygen content too is going to drop. So once you have hypoxemia less than 50, PCO2 normalizing towards 40 or even more than 40, you know that there's a problem with the respiratory system, and that person is actually tilting towards um, respiratory failure in the late stage. So when you do X-ray, what do you see? Normal appearance to hyperventilation, hyperinflation. So you see hyperlucency of that airway, of that lungs, because of retention of air. And of course, one thing about hyperinflation, we already know these findings on X-ray. Hyperlucency of the X-ray. Let me see if we can get an image. Let me see. Hyperlucency, hyperlucency in asthma. I don't think I was able to think of any image. Yeah. So this is what it's going to look. I like this one. So you will see the airway will become very, very dark, hyperlucent. You will notice that the mediastinum is going to be narrow because that that air in that lung is trying to kind of pull the lungs downwards. So it will make the mediastinum appear straight and narrow. That's number two. Number three is the one that we are very familiar with. You can see that this mediastinum is narrow. Then you notice that loss of normal convexity of the diaphragm. Diaphragm is going to become flattened. You see, this flattened diaphragm is a problem. It is a problem. That is what is causing an increase in the work of breathing in people with asthma and COPD. And I'm going to explain it when I get to COPD. That's where it's very interesting. This flattened diaphragm, it is a problem. So, um, so those are the cardinal features that you see. We should not forget the spirometry pattern, the response you get when you do your reversibility, you repeat it at baseline, you give your SABA, you check, you notice there will be an improvement, 12% increase, 200 mil increase, but sometimes you might not get that picture, but you have a high clinical suspicion of asthma, you proceed to the next best step, which is your methacholine challenge. You give your methacholine, you trigger your bronchoconstriction, you measure the test again. You are going to notice that it's going to drop by 20%. So to know the kind of stage, you can do your arterial blood gas to know what you are dealing with. If you do your ABG and you see that your PCO2 is normalizing, getting towards 40, your pH is normalizing, please don't be happy. That person is going gradually. You want to consider NIPPV, non-invasive positive pressure ventilation, or at best, just mechanically ventilate that guy. Particularly if your NIPPV fails within 2 hours. So you really have a trial of 2 hours. Fails, you mechanically ventilate immediately. Intubate, 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 intubate. Very important. So we already know the drugs you use in asthma, your short acting. So we are going to talk about them. It's not so yeah. So let's look at them one by one. So because in asthma you want to relax the bronchoconstriction. So you want to give bronchodilators. There's something you call the reliever medication. There's the controller or the maintenance therapy. So the reliever are the ones that you give in acute symptoms. You quickly want to achieve bronchodilation. So you give the rapid acting beta agonist, beta 2 agonist like albuterol. Administer it sharply, relax that bronchial smooth muscle, the person get relieved. But you might also want to give your maintenance therapy so that the person doesn't have future exacerbation, person doesn't have future occurrence of the symptoms. So in that way, you might want to combine your corticosteroid with long-acting beta agonist like formoterol with an ICS, a steroid like maybe budesonide, fluticasone. We have different combinations. So those are your maintenance therapy. They are there to prevent future exacerbation. They will reduce the inflammatory response, reduce the bronchoconstriction too, and the person doesn't have frequent triggers again. But when the person has acute presentation, that is not when you be giving long-acting beta agonist. You give the short-acting that has a rapid onset of action within 5 minutes, relax that bronchial smooth muscle, and the person is relieved. But it is important to also remember that some of these maintenance therapy have reliever activity. Because, for example, formoterol is a long-acting beta 2 agonist, but it has a rapid onset of action. So you can use it as a reliever therapy too. Don't forget, formoterol, beta 2 agonist, as reliever and maintenance activity. Because reliever, because of its rapid onset of action, maintenance, because of the long duration of action. Don't forget. So that's why when we are talking about asthma, most of the time we keep talking about LABA ICS, LABA ICS, LABA every time is always LABA ICS. If you remember, we pre-medicate a patient with exercise-induced bronchoconstriction. What 2 medication are we going to give? Anybody remember?
Martin Lucas, the leukotriene antagonist.
Look at
And
this
what else?
and lava.
Yes, and LABA and ICS. LABA and ICS. So you give your LABA and ICS 5 minutes prior. You can give your leukotriene receptor antagonist 2 hours prior. Very, very important. So your LABA ICS 10 minutes prior.
The timing again.
So your LABA ICS 10 minutes prior. Your
Okay.
leukotriene receptor antagonist 2 hours prior.
Okay.
So don't forget, you will have tried to step up your asthma therapy, which I'm going to talk about soon. So we have our corticosteroids, the inhaled corticosteroid, PRED, most of the time is always PRED, methylpred, beclometazole. So they are there for long-term control of asthma. This is not the time to be giving max off for long-term control. It is your steroids. And the way they work is that they inhibit synthesis of cytokines to prevent formation of those cytokines that drive the inflammatory response. Your muscarinic antagonist. You have the short acting and the long acting. The short acting and the long acting. Just like we have short acting beta 2 agonist and long acting. So the short acting one is ipratropium. The long acting is tiotropium. You don't use your ipratropium alone. So you don't use SABA ICS. You don't do that. you must combine your SABA, any muscarinic agonist with your SABA and your ICA. You must do that. I don't know why. Maybe um that's to improve its efficacy. But according to the algorithm, you don't use your SABA, your SAMA rather, your SAMA. You don't use it alone. When you look at your patient, you see that your patient is having use of your accessory muscles. You might want to consider SAMA, your SABA, and your ICS. We're going to talk about it. So what do? They block the muscarinic receptor and prevent bronchoconstriction. But before I move further, I'm going to repeat it again when I get to COPD. Giving muscarinic antagonist in COPD actually is to reduce secretion. Giving beta 2 agonist in COPD is to relieve bronchoconstriction. That is it. So, 1 minute. Okay, I want to be sure that we are recording. So, so let me just mention that like that so that it will be conscious in our minds. So, because when we get to COPD, we just be talking about SAMA, LABA, LAMA. That's COPD, LABA, LAMA. So it's not like asthma that is your LABA ICS. COPD is more of LAMA, LABA, long-acting muscarinic antagonist, long-acting beta-2 agonist. So your tioproton is the long-acting one. Your methylxanthine, theophylline, very good in asthma, but we don't use it because of its narrow therapeutic index. It can cause cardiotoxicity, it can cause neurotoxicity. How does it work? It inhibits phosphodiesterase, reducing CMP hydrolysis so that you have more CMP level increased to dilate the airway. So you give theophylline, suddenly discover that the person is having seizures, depressed reflexes, arrhythmias, dizziness, that the person is having theophylline toxicity. You want to immediately check this serum level of the drug and stop it. Chromoline is, the mast cells, the granulizers, sensitors. They stop this, they are mast cell stabilizers. So they don't allow degradation of mast cells. So that's what they do. You can use it in exercise-induced bronchospasm too. It's good. So using acute attack, its maintenance, anti-leukotriene receptor antagonist or lipoxygenase um, blocker. So if you say anti-leukotriene, you are talking about either you are blocking this leukotriene receptor or you are blocking the enzyme that forms the leukotriene. So 5-lipoxyoxygenase is the enzyme that forms leukotriene. That is the enzyme that is active in the aspirin exacerbated respiratory disease, right? So you can block that enzyme so that you don't form the leukotriene. The drug is Xylitol. Or you can block the receptor where this leukotriene works. Telukast is a very familiar example. We have Zifalucast. So once you see the Lucast, glucosamine receptor blockers. So people with the elevated IgE. So you check your serum IgE count is more than 500. You check your sputum sample, high level of IgE and the likes, eosinophils. You might want to consider anti-IgE in that kind of individual. So that's allergic asthma because you have different type of asthma phenotype. So people with allergic asthma that have a lot of IgE, or eosinophils, you can give them omalizumab. It's a monoclonal antibody against the IgE, and it prevents the IgE from binding to the IgE receptor on mast cells because it is the cross-linking of these IgE receptors on mast cells that degranulate the mast cells, leading to allergic asthma. So don't forget, allergic asthma, you might want to consider omalizumab. So by the time we are getting to step 5 of the algorithm, that's when we now start talking about all these omalizumab guys. You can also block interleukin-5 itself or interleukin-5 receptor. So interleukin-5 is a stimulant for eosinophils. So The drug that blocks interleukin 5 itself is MEPO. That's what I just take to my head. MEPO, I move. The receptor, BENRA. So Benra, I think maybe Benrali Tiger or something, or Benga Tiger, somewhere. Once I just see interleukin 5 receptor, I remember benralizumab. Interleukin 5 itself, mepolizumab. So all these ones are very useful for individuals with high eosinophilic count. Interleukin 4 is also a stimulant for IgE. So an individual having anti-IgE, allergic asthma with high IgE, you might want to give omalizumab for anti-IgE or interleukin 4 receptor blocker, which is dupilumab, to take care of the interleukin 4 receptor so that you don't have any interleukin 4 effect on the IgE and you can relieve the asthmatic symptoms. Okay, so let us go to the GINA guidelines, the Global Initiative for Asthma Guideline for individuals that are more than 12 years. So this guideline applies to individuals 12 years above and not pediatric. So Dr. Brinde is going to shed more light on the pediatric. Let me see this question with something we can answer at this level. Okay, no, this is not something we can answer at this level. We are going to go back up to check for. So, how do we make our diagnosis? How do we start giving the medication? So, first of all, you want to make your diagnosis of asthma. So, you do your spirometry pattern, you see the reversibility, you do your methacholine challenge, you see the worsening. Okay, this is asthma. You try to evaluate for the triggers, pollen, dust mite, where the person is living, you take your history. You try to rule out comorbidities. Is this person obese? Is he having GRD? Is the person working in a place that get exposed to a lot of triggers? People that work the welding industry, a lot of metals, people that work in the painting industry, people that work in construction companies, they can have occupationally induced asthma. So people that have comorbidities like obesity, GRD, they can have asthma, and some other stuffs like that. So you try to evaluate for the comorbidities, then you ask for the patient preferences and the likes, then you start your medication. So once you are sure that okay, what you are dealing with is asthma, you start your medication. But we need to know what we are dealing with, the grade, before we know where to start from. So it occurs in steps. So the way to look at it is that step 1 is for intermittent asthma. Step 2 is for mild persistent. Step 3, moderate persistent. Step 4, severe persistent. Step 5 is the person is going gradually. It's still severe persistent and the person is going. That's step 5. So if the person doesn't get improved with step 5, you have to take the person for prayers. So that's your light hand. So so what we want to do is I want to take history of the severity of the symptoms. So how bad are these symptoms? So first thing to put at the back of our mind is the starting number is 2. You ask the patient, how many times do you have these symptoms in a month? The patient tells you, I have it less than twice in a month. That is intermittent. It's not very common. In a month, you are just having twice. You are doing fine. Intermittent. You ask another person, okay, I'm having it more than twice, but it is less than, so not in a month now, but it is more than twice, but less than 5 times in a week. Oh, this is worse. This is mild persistent. For the moderate and the severe persistent, you don't need to worry yourself. What you are looking out for in the question stem is that daily symptoms or nightly symptoms. So once you see that the symptoms happening daily, that is almost 5, 6, 7 times in a week, or 7 times in a week, every day you are seeing it, Monday, Tuesday, Wednesday, symptoms are there. Or the person wakes up at least once at night per week. Please, once at night per week. That is your persistent asthma. So you are dealing with step 3, which is your moderate persistent. Step 4 is not different. It's just that in step 4, their lung function is very bad. So the FEV might be very, very low for step 4. So you catch somebody in step 3 and you are now measuring their functional parameter, the lung parameters, and you notice that your FEV is dropping. You can say that, okay, you need to step up to step 4. So let's go again. An individual having just less than 2 symptoms in a month, that is your intermediate, step 1. Person having more than 2 but less than 5 in a week, step 2. The person is having daily symptoms with at night wakings. The person is having some white wakings at least once in a week. That is already, you escalate to the persistent stuff. So that is moderate persistent. The person is having this but with decreasing lung function, that is your step 4. Step 1 and 2, what you need to give that person is your ICS and your LABA, your formoterol. But how do you give it? You give it as needed. Step 1 and 2, it is as needed. So when the person is having the symptoms, take it, puff it, pa, you calm down. You have it again, puff it, pam. PRN, very important stuff to note. Very, very important stuff to note. But individuals having moderate persistent, that is step 3, in which they're having daily symptoms every day, or at least is waking them up at least once in the night, you need to escalate that treatment. But what do? You are not really doing much different. You are still giving them ICS for formoterol, just like in step 1 and 2. But in this situation, it is a maintenance dose. They have to be taking it every day, not PRN. They must take it every day. But you are starting with low dose ICS, low dose ICS LABA combination every day. For step 4, you are increasing it from low dose to medium dose. Step 4, medium dose. Step 5, you can now add your LAMA to your medium dose ICS LABA for step 5. So step 5 is the lung function keeps worsening. Symptoms are not improving despite being on medium dose maintenance ICS and LABA. Please don't forget this word maintenance. Whenever it's step 3 beyond and the person having daily symptoms and nightly symptoms per week, please, it is daily. It is going to be a maintenance medication. Don't forget. So, for step 4, you give your medium dose ICS LABA. For step 3, you give your low dose maintenance ICS LABA. For step 1 and 2, it is just low dose ICS LABA PRN. Step 3, low dose ICS LABA daily. Step 4, medium dose ICS LABA daily. Now, when you do this and the stuff doesn't improve, you escalate to step 5. You give LAMA to your medium dose ICS LABA, or you don't use LAMA, you don't use medium dose ICS LABA, you just use high dose ICS LABA. Or
Dr. Baba, can you go through this again? I mean, please.
so which part is not clear? Do you understand the step? Do you
The
understand the
step,
steps?
yes, the step 1, I understand. You use the LABA,
No,
ICS,
wait,
PRN.
wait, Dr. Antonia. Do you
Uh-huh.
understand the grading of the step in terms of the symptoms you watch out for to categorize the steps? Do you understand that?
Yes.
You understand that?
Yes.
That is all. We have
Mhm.
solved the problem. So what you just do is that if it is step 1 or step 2, we are going to give them ICS LABA, ICS formoterol, step 1 and step 2, ICS formoterol, but it is going to be PRN when they're having symptoms. You know that, remember, in step 1, it is less than twice per month. In step 2, it is less than 4 to 5 times per week. So it is at that time that they're having it that they'll be using it per PRN, as needed, not daily. But once you get to step 3, step 4, that they're having daily symptoms, night wakings, you don't give it when they have symptoms. They have to be using it maintenance, that is every single day that they wake up. Every single day, they have to be using it. Maintenance. But what is the difference between step 3 and step 4? Step 3, you are using low dose, just like in step 1 and 2. Low dose ICS for formoterol, but daily for step 3. Daily. You give them every day. Low dose ICS LABA every day. Step 4, medium dose ICS LABA every single day. Maintenance dose. If the person doesn't improve with your medium ICS LABA, then you can escalate to step 5, in which you add your LAMA, your LAMA, your LAMA to your medium ICS LABA medication. You do your phenotypic assessment. You even look, guy, come. Do you have any problem? Do you usually gain any weight that you haven't get? Or let me even check your eosinophil count. You notice that this person is having eosinophilic asthma, just like we have here. You might want to introduce something that is going to take care of that eosinophils, which is what? Anybody can guess. What medication are you going to give?
For the eosinophil, we are giving omiluzumab.
Which one?
Um,
What do we call it?
Omiluzumab.
Malizumab.
Malism. Okay, you can do. But what agent that target eosinophils directly? Not even
Mepo,
IG. Hmm?
Mepo,
Yeah,
Mepo.
MEPO, MEPO, interleukin
Oh,
5, interleukin 5, interleukin 5.
Immunotherapy.
Yes, interleukin 5 directly, MEPO, or interleukin 5 receptor. That is Benra.
okay.
This person is
When do you give the anti-IgE?
yeah, so when you do IG count and is elevated too, you can introduce your anti-IG. So it's also common in allergic asthma. People that have allergic asthma usually have elevated IG. So you had your omalizumab. So, or if that doesn't work, you can now consider your high dose ICS LABA. So the algorithm can be confusing because this is the first time we are seeing it again. But um, with time, we definitely get used to it. So we just need to know that step 3 onwards, it is daily medication. Step 1 and 2 per PRN as needed. And you are always giving your ICS and your LABA until step 5 where you have to add your LAMA to it. So let us look at this question and see if we can solve it. So,
Sorry, can I ask a question, or we should wait until after?
okay, let's have it now.
Okay. So the question I want to ask you, sir, is I noticed you've been very, very silent about the salmeterol, you
Oh,
know,
okay.
in the treatment, in the initiation of asthma treatment. So I want to know when exactly, salmeterol, because I know in a lot of questions it comes out when it plays, when you actually use salmeterol, or you don't really use it in management of asthma.
Yeah, we use it, but most of the time when you see questions relating to USMLD, most of the time it is for formoterol. I think the reason why we consider formoterol is because of the fact that it has both reliever
The
and
shot.
maintenance effect.
Okay.
So
Okay.
most of the time it is formoterol that you see. The only thing I know that they change is the ICS. So they can put fluticasone, they can put budesonide, they can put any. In fact, you see some funny drugs. They get plenty drugs, but you don't need to worry yourself about all those medications. Once we understand this algorithm, we'll know what to do next. We are going to see a couple of questions and would appreciate this. So,
Baba, can you please give, like you said, step 1 is mild intermittent and the second one is mild persistent. The
yeah,
stage 3 as well,
moderate persistent,
with
then
moderate persistent, for severe
severe,
persistent.
yes.
Stage 5 is one. I thought you mentioned stage 5.
No, stage 5 is still continue severe persistent. Maybe life,
Gradual, the person is going.
the best is
You
going.
said
So
okay.
it's still like continuation of your severe persistent. Okay, so a 34-year-old man comes to the office to re-establish routine healthcare. The patient has a 9-year history of asthma, for which he uses an inhaler containing a combination of both inhaled corticosteroids and long-acting LABA as needed. For the past 2 years, he has been using this combination inhaler about 3 times per week. So in what can using this information, just this 3 times per week, what do we think the category is going to be? Just 3 times per
Step
week. Step
two.
one?
It's
Step
going
two.
to be step 3.
No.
Step
3 times per
two.
week.
Step
Okay.
two. Step two.
So
Step
step 2.
fine. Because it's not more than 5 times per week, right?
Less
So
than
and
5. And it's less than for step 1 is less than 2. So it should be step 2.
yes, but you will see that something will happen now. His asthma symptoms wake him from sleep approximately once per week. So what is that?
Step 3.
Step three. Step three.
Step
So this
Yeah.
patient has seasonal allergies to ragweed, but he has no other medical conditions and takes no other medications. He demonstrates excellent inhaler technique in the office with good synchronization and breath holding. So it means that this person is actually using the inhaler well. And those are those things you want to check first before you even step up your treatment. The patient does not use tobacco, alcohol, or illicit drugs. Family history is significant for asthma. In his grandfather, the vitals are normal. Lung auscultation indicates normal breath sounds without wheezing. Heart sounds are normal. Which of the following is the most appropriate next step in the management of this patient? So, which one are we picking?
Daily labor ICS.
Daily labor ICS.
Yeah. I expect everybody to call
Mm.
us this answer. We already know these are
Well,
very.
it's so tiny, Dr. Mamali. We're still
Are
trying
you
to look.
Yes,
serious?
I'm
Ah,
I'm straining my eyes
So
honestly, even with the
tiny,
last.
and I can't even
really?
find the
I
option.
will have expanded. Just let me know. I will have
I
expanded.
beg, it's fun. Thank you
Oh,
so much.
thank you so much, Dr. Mamali.
Sorry, wait. Let me see if I can. Sorry. No. Okay. Can we see it better now? Is it
Yes,
better now?
it's better, much better. Thank you.
You're welcome. So, add a long-acting muscarinic antagonist. This one will be needed for what?
That one is Lama. That's the last stage.
That's the last
Stage
stage.
7.
Stage 5.
Mm.
But this guy is not up to stage 5 yet. So why
Mm.
should we be adding Lama? Add an oral systemic corticosteroid daily. Is it only systemic corticosteroid that the person will be taking? No.
Mm.
So, and it's not even oral, it is inhaled corticosteroid. So, continuing his current ICS LABA combination inhaler as needed. Should this person still be taken as needed? No.
No, that should be for 1 and 2.
Yeah. So, perform allergy desensitization. No. Don't do allergy desensitization at this stage. So, and schedule is ICS LAMA combination inhaler therapy daily. So, this
Yes.
is what you do. At this stage, you have to step up that treatment to your step 3. So, you can't be taking ragweed and be desensitizing. That doesn't make any sense. So, what you just have to do is just, step up to maintenance therapy because this person is stage 3. So, you need to step up to maintenance therapy and be giving the person the medication daily. That is it. So, hope this is clear to every one of us.
Yes. It's clear.
How to close this guy now? It's Wala now.
So for stage 5, you
Mhm.
have to assess phenotype and then add the llama.
Yeah, you have to assess the phenotype and sorry, let me see if I can I can't find the course to. Let me just close it here. Okay, yeah. So you have to assess the phenotype, or you add llama, assess the phenotype, change. If there's any biologics that you need to add, then sometimes you might want to consider high dose. The reason why you don't start high dose ab initio is because if you start high dose, you have a lot of steroids getting into the system. That's why you don't take it orally. You take it inhaled so that you can limit the systemic bioavailability. But by the time it's getting high, definitely it's going to get into the system. Person will start developing secondary adrenal insufficiency, Cushing syndrome, osteoporosis, cataracts, hypertension, and the likes. So you want to give high dose at the last resort. You add your llama. If it doesn't work, you do your phenotypic assessment. You give your biologics that is due. And if that doesn't work, you can now consider for high dose stuff. So that is that about the treatment. Just look at the symptomatology. Once you identify nightly stuff there, it is step 3 beyond. Like it is going to be step 3. So you know what appropriate thing to do at that time. So when to step up medication. Before you step up medication, you have to assess that the person is using the inhaler technique very well. The person is positioning very well, doing the normal techniques. The person is adherent to his or her medication, and the person is, of course, avoiding environmental triggers. And you confirm that what is happening at that moment is due to asthma before you can now step up the medication. So I don't want us to really bother ourselves about the alternative track. Nobody asks us about the alternative track. And they are basically similar for all the steps. Step 3 beyond, the alternative track is similar. The only difference is step 1 and 2. So the step 1 and 2 for the normal track, the primary track is very simple. You just give your ICS LABA as needed. It's very simple. But in alternative track, what you just do is just, for step 1, you use SABA as you are taking your ICS. You use your SABA just like normal stuff. In step 2, you use, what's it called? I think I didn't really pay much attention to that, alternative therapy. I don't think we need to worry ourselves about it. I think we use ICS maintenance only. Yes. ICS maintenance only in step 2 for alternative track. So instead of giving ICS for LABA, ICS with LABA, PRN for step 2, you have to be giving ICS only daily for step 2. So that can be confusing and doesn't. And since it's alternative, we don't need to bother ourselves. Nobody will ask you about the alternative. They will always ask you the preferred track, which is step 1 that we are doing. So step 1 and 2, ICS, your LABA, PRN. Step 3, low dose, ICS, LABA, daily. Step 4, moderate dose, ICS, LABA, daily. Step 5, moderate dose, ICS, LABA, daily with LAMA. Doesn't work, phenotypic assessment, add your necessary biologics. Doesn't work, consider high dose ICS LABA. Like, that is it. And mind you, all what we are talking about is just stable asthma. This is stable asthma. This is not acute exacerbation. So somebody comes into the hospital setting, person is having rapid, difficulty in breathing, severe difficulty in breathing, person is having cough, the chest tightness, that okay, this is an acute event. So there's an algorithm that we need to follow. I think I wrote it somewhere here. I think it's here, yeah, so it's here. So the first thing you want to do is to maximize expiratory flow. You want to maximize expiratory, because what is happening in that exacerbation is that maybe there's a precipitant, maybe there's upper respiratory infection, the person got exposed to strong fumes that triggered bronchoconstriction and inflammatory response, and there's narrowing of the airway and the person couldn't breathe. So the first thing is you want to give a reliever medication to maximize that expiratory flow. So what do you give? Most of them might not be able to take something orally. So that's not the time to be giving oral boost, what's it called? Bronchial agonist, um, vital agonist. So you give your agonist in nebulized form. So you use your nebulizer to administer into the airway. They might not even have energy to be using a inhaler and be using a inhaler. So you have to drive in the stuff into the nose using your nebulizer. So you use your nebulizer to administer your short-acting beta 2 agonist like albuterol to relieve that bronchoconstriction first. So you can repeat this 3 times. You typically expect improvement within 1 hour. So within 1 hour, you can check for the clinical symptoms. Normally, you should see that the patient is now stable. The person is the breathing rate reduces, the dyspnea reduces, the wheezing reduces. Or you can, this is where you now use your peak flow meter. So you give them the peak flow meter, tell them to blow. You notice that there's improvement in the peak expiratory flow rate. But you don't even stop at your beta 2 agonist. You don't stop at that point. You must give them steroids. You must give them steroids because you want to prevent, you want to relieve that ongoing inflammation and also prevent future exacerbation. So you need to give them steroids to reduce the airway inflammation that is happening because it is not only bronchoconstriction as the problem, there's also inflammation. So you give your steroids, can give your IV prednisolone, IV methylprednisolone, and to take care of that inflammatory response that trigger that acute episode. Then you typically administer it within 4 hours, of presenting in the hospital. So then you also watch out for improvement. Usually, if you see that when the person came in, the person is using the accessory muscles and it's really very bad, you might want to start your maximization of your respiratory flow, that is limiting the bronchoconstriction with a combination of your SABA and your SAMA. So you might want to combine SABA with hypertropium when you notice that, okay, this person is actually using coastal muscles like this. So much use of the secondary accessory muscles. So instead of using SABA alone, you might give your SABA plus your hypertropium with your systemic glucocorticoids like prednisolone or methylprednisolone. Then you watch out for improvement. In some situations, you might need to escalate the treatment to the use of magnesium sulfate, particularly in people that are tilting towards severe asthma, severe acute asthma. We don't really need to know the algorithm of mild, moderate. Nobody's going to ask us. Nobody is going to ask us. Most of the time, they don't even test the use of this magnesium. They don't really test it, you know. But it's good to know that if an individual presents to the hospital, usually with FEV1 less than 25 to 30% of normal, FEV1 that should be 80 to 120% of normal for the person's age. If it's less than 25 to 30%, you might want to introduce magnesium with your other SABA, SAMA. You might want to introduce magnesium to achieve maximal bronchodilation. Or if you notice signs of impeding, severe asthma, after you have used your SABA, you have used your SAMA, and you still notice that the bronchoconstriction is still severe, you can now give magnesium. And the pointers is that you notice that the patient starts becoming agitated, the person will be having wheezing at both inspiration and expiration. So you might want to introduce magnesium to help you with your bronchodilation. But most of the question stem might not really test that. So what they want you to identify is impending respiratory failure we have been talking about, which is what? Hypoxemia, when you notice that you do your ABG, your oxygen level is less than 50, hypercapnia or pneumocapnia. Hypercapnia or pneumocapnia when either your PCO2 is normalizing towards 40, or usually when it's greater than 50 and it's getting bad, you need to help that patient. Or the person is having confusion. You cannot talk to that patient. The person cannot respond to you. The person is confused. There's a problem with the sensorium. this patient is going. The patient is becoming cyanotic. Cyanotic. You have to do something. And most importantly, when the chest is what? The chest is silent.
Silence.
So you might want to consider for intubation in that kind of presentation. So you see your PCA2 more than 50, PaO2 less than 50, silent chest, altered sensorium, those four things, clinchers, intubate immediately. Immediately. But if it doesn't get to the level of intubation, you give your short-acting beta-2 agonist, you give your systemic glucocorticoid, intravenous prednisolone, and the patient improves, and the patient wants to go home the next day, you must continue the patient on short course oral steroids for at least 5 to 7 days to prevent future occurrences. Very, very important. So, the initiation and the adjustment of this maintenance therapy, and of course, don't forget oxygen. Oxygen is important. So you give oxygen, particularly when the SpO2 is less than 88. So you want to take it to about 93 to 95. So you have to give oxygen. So the algorithm is maximizing expiratory flow by giving your bronchodilators, which can be in form of SABA or SAMA, your albuterol or your ipratropium. You want to limit airflow inflammation, airway inflammation by giving your systemic glucocorticoid. You want to improve oxygenation by giving your supplemental oxygen. You also want to give ventilatory support when necessary. And when do you need ventilatory support? When do you need ventilatory support? When PaO2 is greater than 50, when PaCO2 is greater than 50, when oxygen is greater than 50, when the chest is silent, when the person is cyanosed, when the person is having confused state. The person is agitated, confused, not rational. You know that the person is having problem. So you need to ventilate that person. Very, very important. Some
So,
okay,
so
Dr. Antonia, you
Doctor,
want to say something?
yeah. So with the magnesium, you said when there is severe bronchoconstriction and you were giving the percentage, give us a percentage. What's the percentage again, please?
So uh less than 25 to 30. So when you about 25 to 20, 30%. So
Okay, 25 to 30%, less than 25 to
30%. Yeah.
30%.
You know
Is
that
it
most of
of
the
the
time
EV1?
FEV1, FEV1.
FEV1, yes.
But you know that most of the time when they come in, you don't even have time to be doing FEV, blah blah. So because this is the US, they have so many, instruments to be doing all these things quick. But ideally, you just start with those things that we have talked about, your SABA. If the person is using accessory muscle, you include your SAMA, and immediately you give your IV steroid. Then you watch. Person is not improving, you can, and it has not gotten to the level of altered sensorium, cyanosis, PO2 less than 50, you can now give you magnesium. But definitely, if the person doesn't improve with magnesium, it's going to escalate into all these things. Then you can now consider for intubation. So that's the way it works. That's the way it works. So don't forget expiratory airflow, airway inflammation limitation, oxygenation, and ventilation when necessary. Those are the four things. Once you know that, for acute exacerbation, you can treat acute exacerbation of asthma, you can conveniently treat acute exacerbation of COPD. That's the algorithm to follow. Very, very easy. So, we have talked about this,
So
uh,
you follow the same step for treatment of acute COPD.
yes, acute exacerbation of
Okay.
COPD. We are going to get there. You just add one or two things, but this is basically, what you do. You don't typically give antibiotics in asthma and stuff, but in COPD, you might want to consider antibiotics. We'll get there, don't worry. So, initiation of treatment is determined by the asthma severity symptoms at baseline. We already said this. So, that is going to determine the step you are going to place the patient and what you are going to do accordingly. Therapy may include combination of controller, your salmeterol, your ICS, and reliever, which treat your exacerbation acutely, which is albuterol. So albuterol has reliever medication. This salmeterol ICS is just for controlling or maintaining, you know, certain medications like formoterol and ICS have both control and reliever effect. Dr. Dorothy, I think these have answered your question.
Yes.
So
Yes, absolutely.
so you might need to step up or step down depending on the intensity of the patient. So you regularly, evaluate the patient. So we are not in respiratory rotation. So we don't need to delve too much into those algorithms that when do you need to see the patient. Nobody's going to be asking us all those things. So the major thing to focus on is what you do when emergency situation comes in. That's what your question stem is going to be talking about most of the time. But sometimes you might also need to know what to do, for stable asthma, which is the stepping up, stepping down routine. So corticosteroid inhaled in a rush can lead to thrush. Corticosteroids, when they are taken in, they can suppress the immunity of the oral mucosa, so leading to candidiasis. But the commonest presentation is not actually candidiasis, but candidiasis is what we usually talk about. Most of them have laryngeal myopathy, so they have hoarseness of voice leading to dysphonia because of the weakening of the laryngeal muscles. So you usually advise them to gargle, after they use it, rinse their mouth and spit out the water. Or if it's, a younger person, you can use spacer device. So spacer device is going to limit that, um, what's it called? Uh, deposition in, the localized area that can be causing all these things. So just go straight into the airway, does whatever it does, and it doesn't concentrate and settle in a portion, with the use of spacer. So adult and adolescent diagnosed asthma, even mild forms, you need to use ICS to control airway inflammation, just like we said. And this ICS, the inhaled corticosteroid, they have a lot of benefits. They improve the lung function because they limit the inflammation, they improve the lung function, and of course, most importantly, they prevent severe exacerbation. And once you prevent severe exacerbation, what do you do to mortality? Mortality is reduced. Mortality is reduced. So you also use it to take care of exercise-induced bronchoconstriction, in which we talked about giving ICS with your LABA 10 minutes prior to the exercise, and your leukotriene receptor antagonist 2 hours prior to. So we have come to the end of asthma. Let me see if I have maybe one or two. I'm not sure I have a lot of question. Yeah, for asthma, but I know that we are definitely going to find lots in our U. So I don't. Once we know all these things, I'm sure there's no question we'll be able to take care of. Definitely. So
Dr.
okay,
Paula, can I see your last page? There was a note you made there. I just want to go through the notes. Yes.
is it here? So dysphonia. When I was talking about the laryngeal myopathy, so you want to gargle, rinse, spit out, so that you don't allow the corticosteroid deposits in the lungs, in the mouth, and be causing the thrush, the dysphonia, like. So, um, we have come to the end of asthma. So, continue from bronchiectasis and move onwards from tomorrow. So, do we have any question? Any question? Anybody with any question? Anybody? Dr. Dorothy, Dr. Joy, Dr. Um, let me see.
So the relievers are the beta B2 agonists are
Yes,
relievers are B2
the
agonists.
short acting, the short acting, rapidly acting, beta 2 agonists. Those are the
Uh,
relievers. Albuterol, albuterol,
okay.
and of
Then the
course,
control are the
formoterol.
long-acting ones and the corticosteroids.
Yes, formoterol is also a reliever because though it's long acting, it has a rapid onset of action, so it can serve as a reliever medication. So that's why formoterol is the best, because it can help you relieve the symptoms, and at the same time, it can help you, um, stabilize that um, condition so that the person doesn't have recurrent exacerbation, because it also serves as a maintenance therapy. It can act a long time, um, dilating the airway for a long time. And when there's an acute event, it can also dilate the airway rapidly because it acts fast within 5 minutes. So it's reliever.
Okay, so it's that formoterol that acts as yeah, formoterol that acts as LABA, right?
Yeah, yeah.
Okay,
Yeah.
okay. So then the other thing I want to ask you is that is it for any of the stages you have to be, is it or you, is it either, I mean ICS or SABA, or you give both?
Where? Which condition are you talking
I'm
about?
talking about the steps.
You give both. You give
Okay,
both.
because it's a slash, so I don't know. Maybe
No, no,
it's
no. It's combination.
okay.
It's combination.
Oh, thank you.
So you have to give both. Yeah. So that's stable asthma. So you look at the symptoms twice, more than twice, but less than five, daily with nightly symptom, daily with nightly symptom with reduced lung function. So once you see somebody that has night symptoms, you already know that this is likely to be step three. Very, very easy. And you know that what you are going to be giving that person is a maintenance dose. You have to give that medication daily. This is not the time to be doing PRN. So you can do PRN step 1 and 2 using your low dose ICS with your LABA. But once you see night symptom in your question, you know that this is step 3. So you have to change that medication to a daily medication. And depending on the stage, so if it's one that, okay, the initial one, step 3, night symptoms, you might want to start with your low dose ICS.
Maintenance.
Yes. Sorry, excuse me for a moment. Yes.
Dr. Bawale, your speaker is on.
Okay.
Oh, speaker is on.
Yes. Sorry, Moshe, don't be 2 hours ago. Sorry. Okay. Yes. Mi ò ní bí a máa get lẹ́nu. Okay, okay, ma. Okay. Yes, ma. Mo ti pause ẹ. Mo ti pause microphone.